5 on May 20th. And we are turning back our attention to H266, which is up for action tomorrow. And we have a couple witnesses in that we weren't able to have in last week. And I thought I would bring legislative counsel up. I asked legislative counsel to work on a couple things around the amendment that we had proposed last week, and she's made some changes and some tweaks to it. So before we hear any testimony, just thought I'd bring this up. So,
Great. Good afternoon, Jen Carby from the Office of Legislative Counsel. I'm going to put it up as the Word document for right now. Second, just get rid of the entire. I was trying to minimize the people who block my screen, but I made the whole thing go away. All right, there we go. So I think this language is being posted. This would make some additional changes to the language we looked at last week on limitations on hospital charges for outpatient prescription drugs. For one thing, I made this section A and now a section B. Section A would be effective on January 1st of 26. Section B would be effective on July 1st, 25. So treating those periods a little differently. So in the first change here is to say that a hospital shall not submit a claim to a health insurer for reimbursement of a prescription drug administered in an outpatient or office setting at an amount that exceeds 120% of the average sales price as calculated by CMS. And I took out most recent calendar quarter. You'll see why as we go through. That's the only change I made in A and A1 and 2 is just this reference to it being based on 120% as calculated by CMS for the next, for the most recent calendar quarter. And put in a new 3 saying a hospital shall update the average sales price for each drug annually on January 1st and July 1st based on CMS's ASP calculations for the most recent calendar quarter. It's my understanding that currently prescription drug prices are updated twice a year. So this would maintain some consistency with that rather than having it done 4 times a year.
what CMS does 4 times a year.
CMS does it 4 times a year.
Times.
Yep. But this wouldn't require the hospitals and the payers to check that out 4 times a year. Then in the existing language around no balance billing and no sort of cost shifting, this would be a new subdivision 2 saying that if a hospital demonstrates to the board in its budget submissions under hospital budget review that the price cap set forth in subsection A is having a negative impact on access to care, quality of care, or sustainability of rural healthcare services, or a combination, the hospital may propose to increase its commercial reimbursement rates for preventive care or essential community services, or both, and the board shall consider both the demonstrated impact and the proposed increase to reimbursement rates. And then I still have the language saying the provisions remain in effect unless and until the Green Mountain Care Board establishes a different preference-based price applicable to prescription drugs administered in an outpatient or office setting. And then specifying in the carve-out for critical access hospitals, they would say the section shall not apply to an independent hospital that is designated as a critical access hospital and that is not affiliated with another hospital or hospital network based in or outside of Vermont. And then section B would be limitations on hospital charges for 2025. This is a new section. So I was just trying to show you where the differences are between the language in A and this, mainly that it's to 2025 and uses 130% as for what the hospital would be limited to. So a hospital shall not submit a claim to an insurer for reimbursement of a prescription drug administered in an outpatient or office setting between July 1st and December 31st, 25, in an amount that exceeds 130% of the average sales price. And it's my understanding that's based on the way the contracts relate to the amount that gets paid based on the amount that gets charged. As calculated by CMS for the most recent calendar quarter, I left that language in there, for any drug for which the hospital charged any health insurer more than 120%. So still the trigger, but keeping the amount at 130. And then for any prescription drug, again, for which the hospital charged 120% or less of the ASP as in effect on April 1st, the hospital would not charge a greater percentage of ASP for the drug between July 1st and December 31st than the percentage of the ASP that they charged on April 1st. Trying to have a little something for the rest of the plan year that reflects existing contractual provisions and the impact that this would have on those, and then having the language take effect and then sort of the new way starting in January, and have it the ASP recalculated twice a year, allowing hospitals to demonstrate adverse impacts and potentially increase commercial rates for certain types of services. And then specifying that the carve out is for a critical access hospital that is independent and not affiliated with another hospital or hospital network.
Any questions for Jen? A lot of dates.
Some of these would go in effective dates.
And I just will say that I asked her to raise it to 130 for the remainder of calendar year 25, because it's my understanding that there are some payers who pay outpatient prescription drugs as a percentage of what is charged. So therefore, if we say you cannot charge more than 120%, the existing contracts would have them paying a percentage of the 120%, which would lower that, and for less impact if it's up to 130, that gives them a little more leeway in their contract negotiations. And then it's back to 120 as of January, because payer and hospital contracts run starting in January, I believe. And this would allow them to negotiate the new rate as of January 1st of 26. That's why all the dates.
That's the 130. That was my question. So, yeah.
And that's the 130. Okay. Thank you, Jen. All right, so are Kelly and what?
I'm gonna go first.
You're going first?
Yeah.
Oh, okay. You all just tell me who's coming first. My schedule is not the same, I think.
Share my screen. Okay. Good afternoon, Devin Green, Vermont Association of Hospitals and Health Systems. Thanks for having me in today. And I wanted to go through a bit on the impact that the prescription drug cap would have to hospitals. And before I go into detail about each hospital, I wanted to just do sort of a broad overview and talk a little bit about what Chair Black always says, which is, why can't we just pay hospitals for the work that they're doing at the amount that it costs for them to do it? And you'll see here the slide that you've seen many times, which is that Vermont does have high drug prices. But I'd like to put that into context a little bit nationally with some other data, including Medicaid data. One thing that I put together in what's happening at the federal level in Congress is one of the restrictions that they're doing is they are restricting state-directed payments, which allow Medicaid commercial MCOs to pay hospitals at commercial rates. So basically paying commercial rates for Medicaid services, which Vermont very much does not have. 40 states have taken advantage of this. Vermont has not. And you'll see here in this chart that shows when we talk about our Medicaid rates, strictly our rates compared to the rest of the country, Vermont looks okay. But when you look at supplemental payments, which include those directed payments, Vermont is very much on the low end of the spectrum because the majority of the states have really taken advantage of those Medicaid supplemental payments. So that's one factor that's playing into this.
So Medicare is paying other states the difference between the Medicaid price or the Medicare price in commercial.
Medicaid, states have worked out with a provider tax, and I don't know the mechanism. They have worked out a way to get commercial rates through Medicaid and going through the Medicaid MCOs. So they are getting commercial rates for Medicaid. Congress has recently said we need to reduce this so that you can't pay any more than Medicare rates. We would gladly take Medicare rates. Give us your Medicare rates. But that's the reduction that other states are going through right now. Vermont is not going through that because we don't have those rates here.
I was gonna wait, but I think it just makes sense to ask, like, is this only for hospitals or for all providers?
I have to check on that. If you go to the link, that might have more info. The link at the
Payments to
bottom.
hospitals.
You mean to your,
Oh, it does? Okay, great.
no, thank you, and then if you're gonna cover this, I don't have the computer open, so you might just
Okay.
be the next slide. If you're gonna explain why Vermont's drug prices are like, it looked like the highest or second highest in the country or something in the previous, are you gonna explain that? Or do you not know why?
Yeah,
Okay, then I'll
I
wait.
think this all plays into this.
Okay.
It's a method of subsidization. The other piece is a little bit of what you've seen before with the Medicare. So there's a Medicaid piece, others are getting paid more in Medicare, or in Medicaid, sorry. Others in the nation are getting paid more through Medicaid, through these supplemental payments. Vermont hospitals are consistently being paid the lowest by Medicare. These are based off of slides that I showed you before. Southwestern Vermont Medical Center is getting this through a data group called the Advisory Board. And this just illustrates again that Vermont is consistently paid the lowest by Medicare.
All the hospitals, yeah.
Yeah. Yep. When we've even gone through at the individual hospital level, other hospitals have been paid several times the amount that even UVM Medical Center is paid.
So these are very, very generalized services. I mean, these are not specific. So Medicare pays, is it the DRG? Or they pay a DRG based upon the patient's diagnosis.
Yes.
Essentially.
Yep.
Couldn't we also say that we're healthier?
No, again, because these are, it seems unlikely to me that we are just healthier. I think if we were doing a per capita, that would be, we're healthier because not everyone's going to the provider. These are people who are going to the providers. They're in the hospital already. I would also point to this slide that I'm on that has E&M, which is a code you're very familiar. Those are codes you're very familiar with, and they are more specific and we're still well below other states in that area. In fact, to move us to the median would be an increase of 105%.
So is this all being, and I see you, Mari, is your slide, because you had this slide before, or slides making similar points. Is the contention that the regional I don't remember what they call it, whatever they include in a various payment amount, which is based upon your region or your health,
Right.
what they calculate.
They have
They,
wages and geographic index, yeah.
yeah. So is your contention that Vermont is like the lowest of every single state? Because, I mean, if that's your argument, I can see that, but what is that number? What is every state's number?
In terms of,
What does Medicare think it costs to provide care in the state of Vermont as opposed to what they think it costs to provide care in 50 other states? 49, because there's only 50 of us.
in terms of, you just want to look at one service, is that what you're saying, or?
I'm thinking of all services. They generally try to adjust for the region. So what I'm saying is what is our adjustment that they're making for us? And how do we compare with every place else and their adjustments?
I am happy to come back with you. I'm happy to come back with that information, but I think what we're seeing is that the adjustments have been wonky for Vermont.
Mara,
My first question was why? What do you believe is the reason why Vermont is being less? But also I need help understanding what am I looking at in the previous slide? Both sides actually. What does the $7,839 represent for Vermont? Some number of total spending on general medicine from all hospitals in a year?
No, I think that's the amount, that's the, like,
One patient
Yes.
receiving
Yes.
general medicine services in a hospital
yes,
would get reimbursed that.
yes.
So this just seems like a lot of variables that could go into that, including what Representative Black mentioned about there's all sorts of different diagnoses that could fit in general medicine, some more costly to treat than others. And it's just hard for me to wrap my mind around.
Yeah, I agree. And I think there's a lot of variables that I think Vermont is unique in that we have a lot of other variables on top of what's happening in the rest of the country in terms of we do have the Green Mountain Care Board, which limits your net patient revenue, and that includes your Medicare. And so you're cutting certain Medicare spend. That ends up cutting Medicare reimbursement for critical access hospitals. So there are impacts there. And then we also have the all-payer model. We're not sure how that played into it, but we do know that it saved Medicare hundreds of millions of dollars. And so I think we are an outlier for some of those reasons.
But the care board can't tell Medicare how much to reimburse specifically for a patient's general medicine care.
No, it can't do that. But when the Green Mountain Care Board says your net patient revenue must decrease, that includes everyone. That includes commercial, Medicare, Medicaid, that's decreasing everything.
I'm just looking at your slides here really quickly. So this data is from Southwestern Medical Center, correct?
They got it for us.
And is it just for Southwestern?
No, it's for the state of Vermont. They started looking for themselves and then they got curious and pulled other data.
So they got data from other hospitals?
No, they are working through a group called the Advisory Board because they are trying to get close to the Medicare. They are trying to get their numbers with what's happening with reference-based pricing. They are trying to get their costs down to the Medicare reimbursement amounts. And so they are working with a consultant and the consultant was able to get them these numbers. It's called the advisory board. I should have put that on there.
Sorry, Mari, I interrupted you. I feel like,
Been done.
okay, thank you.
So all of that is to say that healthcare financing there's a lot going on. There's a lot of supplementing, and there are a lot of different ways that different hospitals are doing it across the nation.
Oh. Okay, go ahead. I'm sorry.
The main point I want to make here as we go into the other hospitals is that this price cap impacts hospitals beyond the 46 million. That was just for Blue Cross Blue Shield. And this cap goes to all payers. And so it does have a really outsized effect on hospitals, as you'll see. So for Northwestern Medical Center, what this would do, the 120% cap, it would result in 2.5 million in cuts. There would be they would need to close their infusion center in addition to the 2.5 million in cuts. So they would have to close their infusion center, and they would also have to find a way to save 2.5 million. They're challenged because they purchase their outpatient prescription drugs above ASP. So capping reimbursement at 120% ASP would leave them with very little margin. Their financials are at negative 2.5% operating margin, or negative 3.4 million. And on top of that, with hospital transformation and the Oliver Wyman report, their recommendation was that they grow their hospital services, which they'll be unable to do here. So part of the services they were asked to grow was colectomy, OB/GYN, and birthing services, breast and prostate cancer care, ICU beds, and cardiology. Southwestern Vermont Medical Center, their cut, and again, they've been touted as a very efficient hospital. They have tried really hard to get close to Medicare costs. Their cut would be 8.8 million. That would be an impact of 12.5% of their workforce, or 125 to 150 FTEs. Their financials are, their margin is at 0%, or, if they have $17,000 as their operating margin for FY24. Again, they were also asked to expand their services under the Oliver Wyman report: mental health capacity, geriatric site, cardiac labs, cancer care options, a PACE program, ICU beds, inpatient dialysis. They would have to make cuts instead of grow. Rutland Regional Medical Center, their cuts would be $16 million. They have for FY 2024, they had a 0.9% or $3.2 million operating margin. And they were also asked to grow their hospital services, expand orthopedic spine surgery, ICU beds, add dialysis, consider becoming a level 2 trauma center, increase OB services, open an emergency general surgery center, and consider establishing a center for robotic surgery. Those would not happen. And they would also have to make significant cuts. Brattleboro Memorial Hospital is interesting. It has its own status as a Medicare dependent hospital. And to do that, you must be located in a rural area, have fewer than 100 beds. I think Brattleboro has about 50 beds, and have at least 60% of your inpatient days attributable to Medicare and have high Medicare utilization. So they don't have as much, with that high Medicare. They may need, supplemental payments from the federal government. Their financials are negative 5.1% margin or negative $5.8 million. Oliver Wyman report also recommended that they grow and add dialysis, grow their OBGYN, grow orthopedics, and grow general surgery. Sure.
So all these hospitals you just mentioned, this would be the result of the 120 cap.
Yes, these cuts. And I will, oh,
So the rest of the hospitals would be okay?
well, now we're adding more critical access hospitals into the mix, right? So this latest provision added Mount Escutney and Porter, and I haven't had a chance to get those numbers.
And these were just critical hospitals.
These are prospective payment hospitals. They are not critical access hospitals. You know, in my mind, all the hospitals are critical.
True.
So,
True.
and I will leave the EVM Health Network to talk about how the cuts will impact them. I want to get into some of the smaller items in this legislation, and then also the broader picture. One of our hospitals pointed out, and I think maybe this is what you're trying to get to in the new language, that the 120% would, under the current language, because you can't submit a claim for 120%, that the insurers would then add their discount on top of that, so it would actually be lower than 120%. I have to look at your language and see if that would help, but I think going forward, if we're really doing reference-based pricing, it shouldn't be a part of negotiation. It should just be a set amount that you're being reimbursed. So I would propose that hospitals know the percentage that they're getting when it comes to a cap, and not have further discounts
Do you
added
have the
on.
data for that?
The data for the discounts?
Yeah, for the difference, yeah?
I don't. I don't have the data for the discounts, no. A couple of our hospitals got back to us about ASP as a benchmark. Like I said, there are hospitals that buy higher than ASP for various reasons, which would make 120% pretty tough. And then there's also the 6-month lag time, and drug prices can fluctuate anywhere from 10 to 12%, again, impacting prices there. For new drugs, Medicare is doing wholesale acquisition costs plus 3%, mainly because they can't set the ASP at that point when the drugs are so new. They're not sure where it will land. It's very volatile. So we're really looking for some flexibility in the benchmark, or to match the national average, which you saw from that first slide was much more around 300% than 120%. As you saw with the information on the hospitals that I presented, cuts to services will happen under this drug prescription cap. The language I saw here was new in terms of the hospitals could go and ask for increase in reimbursement for certain services. Given the magnitude of the cuts, I think it would be challenging to get to the right rate in time before cuts need to happen. And so I would need to understand more about how that process would work, and if it really would prevent cuts in access to care. Because we're in still a fee for service model. The most likely services that will be cut are the high expense, low reimbursed services that we see. And those tend to be very important services such as OB and various other critical and community services. One way that we could avoid the magnitude of the cuts is either applying this cap to our domestic insurer, and that would at least give us a better sense of how much the cuts will be. They have told us that it's 46 million. Maybe that's something we can wrap our arms around, or apply the cuts to the QHP plans. And again, both of these we would think would go towards the stated objective of helping Blue Cross Blue Shield remain sustainable and reducing those premiums that have been proposed so far. The other thing we would like to keep in mind is that the sort of interconnection that this proposal has with everything else going on. So as I mentioned, this will have an impact on the hospital transformation work that's happening and the ability for hospitals to take on new services or new volume. It has an impact on H482 and using that tool as if Blue Cross Blue Shield gets to a place where they need their reimbursements or where they need to use 482 as a tool to save them. Hard to say that there will be hospitals available to do this with the cuts that are happening to them. And maybe it's a chicken and egg thing. Maybe they won't get to a place where they're insolvent or near insolvency because of this proposal. But I want to make sure that people understand that. There's a 2.5 operational expense reduction of 100 million. That we are assuming that this cap would go into that $100 million number, and that 100 million would not be on top of this cap. But that also means that the 100 million may just be this. It may just be the sort of more blunt instrument. There's reference-based pricing and how making these cuts will play into that and the impact it will have there. Hospital global budgets, and then the FY26 hospital budget as well. So with that, that is what I have for you.
Questions for Devin? Tupper?
So, as I look at this, off the top of my head, what this says to me is the things that we want to do. Number one, save the hospitals so that they stay there. It's impossible. That's the first thing that comes into my mind.
I wouldn't,
If we continue operating the way we are right now, they're gonna go away.
I think that's right. I think that hospitals are really engaged in this moment and moving quickly to find savings. And so I understand this committee's need for expediency and wanting to do something immediately. Again, I do want to point to that this is bigger than that 46 million too. So it will have a big impact on the hospitals.
Yeah.
Can you go into detail a little more for me with your proposal cut applies only to domestic insurers or cap applies to qualified health plans?
Yeah, so so is there a way to limit this to just Blue Cross Blue Shield, that this applies to Blue Cross Blue Shield's rates and the rest of the rates stay in place? And so this is more of a pilot project to see how it goes. And then if that's not possible for whatever reason, I know that Blue Cross Blue Shield has difficulty with its its qualified health plan. So the plans that are on the exchange in the individual market, the small business market, can we apply this cap just to those plans as opposed to every plan?
So it's and or, it's not.
It's a or, it's a
Okay.
hard or.
Okay, all right. Well, that's what it's stated.
Can I ask a follow-up to that?
Yeah.
Because as I was looking at your slides, how do I look at somebody who has MVP in the eye and say, you're gonna pay 5,000 for this, but you have a qualified health plan under Blue Cross Blue Shield, so we're gonna reduce it for you to 100. How do I look them in the eye?
But how much are their rates going up?
Well,
I mean, the
I would say
20%
everybody's rate.
at the, we have identified Blue Cross Blue Shield as that rate is unacceptable, right? And so this is a way to get at those unacceptable rates without significantly cutting services at hospitals. Because the other thing we'll have to look them in the eye about is this service is being cut in your hospital, and once it's cut, it's not coming back.
I would say that everybody's rate is going to go up starting next year. I have MVP. I can't afford the plan as currently configured now. At the rate it is now. It is unaffordable. I will go without health insurance next year. The only reason I'm able to afford it is because of that tax credit and the subsidies. And that's going away. So again, how do I look at somebody with MVP and say, not for you, because Blue Cross might be insolvent, but MVP is decided that they'll stay in Vermont for another year? And how do I also say to a small business, not for you, small group market, but for you, individual plan? Or for that matter, how do I look at a state employee? How do I look at my 149 other colleagues in the eye when the state employee health plan has lost, I don't even know how many tens of millions of dollars over the last couple of years that the general fund will have to backfill?
I understand.
How do I do that?
I'm telling you the impact that it will have on hospitals. And so we will have to look people in the eye and tell them something. And we need to understand what that is. And that's what I'm making sure I do here today.
Daisy, did you have a question?
I did. Can you go back to slide 13, Devin? I think there were some points made on there, and I was just curious where they were coming from. It wasn't clear to me, but they seemed very definitive, and I just wanted to be sure that we were all understanding where those kind of endpoints were from. The high expense, low reimbursed community services are more likely to be cut. Can you speak to that a little bit? How do we know that?
I think that is just the reality under our current fee-for-service system and the way that we're reimbursed right now. If it's so this is coming into play before reference-based pricing happens, right? Or global budgets happen. Under those models, there's an opportunity to change how hospitals are paid for providing their care. In FY 2026, that's not the reality. And so when making these cuts, hospitals are going to have to look at cutting the high expense, low reimbursement services. Those tend to be not things like orthopedics, but things like birthing services and dialysis.
Okay, I wanted to make sure that you weren't speaking in reference to federal cuts that are happening. And also, I just think in general, as we talk about these things, we have to remember that the setting that these changes are gonna be taking place in isn't the setting that we're in now, right? So like, that's what came to mind when you were going over these hospitals. Each hospital had a slide with their current operating margin and then the cuts that the Wyman report had recommended. You know, those individual hospitals are gonna look completely different at the time that, you know, we're implementing this bill or the legislative changes brought by this bill. And so I think that's just something that this discussion really brings up in my mind is it's just a completely different climate. And I think we're designing for the future here and we're not designing for today.
I mean, I would argue that this proposal designs for today. It goes into effect pretty immediately and will have pretty immediate consequences. The hospitals, I did FY '24 because those are the actuals. If you click on the links, you can see the first quarter, the FY '25 first quarter, and you'll see that nothing is I don't think very much has drastically changed with the hospitals. So I would say that this cap will be going into effect for the hospitals of today, and the world will not be very different when this goes into effect.
Just to how many times, obviously, clearly enough times that you say, as I always say, I cannot, I can't move beyond the immorality of this. I just can't. And I know, I understand we've got to make our money here so we can put it over there. I'm sitting here and I'm looking at information. You had Mount Escutney and you had Rutland Regional up on your slides.
You don't have Mount Escutney.
Well, I thought you said something about Mount Escutney. I thought one of them was your.
Well, now Mount Escutney is included under
don't
the
have-
new, I don't have them.
Okay. Let's go to Rutland Regional. Information we received. Remicade, which is an anti-inflammatory. It's for somebody with like Crohn's. ASP, average sales price on that right now, if you were on that drug for a year, be $8,064. Right now, Rutland Regional, if you're a patient with Crohn's disease and you're having your injections or infusions, I'm not sure how, I'm sorry, I apologize, I don't know how Remicade is dispensed. The Blue Cross Blue Shield is reimbursing Rutland Regional $96,000 a year. How do I look that person with Crohn's in the eye when they have no choice but to get it at their local hospital? They've got nowhere to go.
And
How is this not price gouging? I'm sorry, I can't.
And I am here to do the work on this piece and to limit the amount that hospitals are receiving under prescription drugs. We would like to do the work on that. The Green Mountain Care Board has that ability through its reference-based pricing to do that. I'm here today to inform you of the impact of this proposal that's on the table and goes into effect pretty immediately that it will have on the hospitals.
Any other questions?
Well,
Leslie?
this isn't really a question, but I can't help but think that if Rutland Regional is dependent on that kind of difference for its survival, there is something really fundamentally wrong. I mean, we sort of know there's something very fundamentally wrong. And how can we let that persist is my question. How can you propose that to persist?
I'm not proposing that it persists. I am saying, can we limit this to Blue Cross Blue Shield? Can we limit this to QHP plans? Can we start there? So that it is not such a large magnitude of services being cut.
But it continue, that's only one drug. How many other drugs also? How can a business model be so dependent on this, which feels really wrong? That's the question for me.
I think that's just a statement that
That's just a
national healthcare
statement. It's a statement, but how do we deal, but how do we survive in this state?
Well, if Green Mountain Care Board gives hospitals that are affected drastically the ability to raise their prices on those very services that you're talking about will be cut, because we always know that the first thing that gets cut are the services that are actually vital.
Due to the current payment model.
Okay, due to the current payment model. How do we? Does that address some of that? To give the Green Mountain Care Board leeway to be able to say,
Will it be done fast enough?
it'll be in this year's hospital budget?
But it is a process where the hospital has to go to the Green Mountain Care Board and ask for it. And then they have to go, and the Green Mountain Care Board grants it, and then the hospital has to go back and negotiate it with the payer, right?
The act doesn't take effect until July 1st. Which means we'll have real data on any impact. By the time, actually, no, when do hospitals put in their budget? August.
July 1st.
Okay. Budget order to come out in October
Yeah,
or September.
October 1st, yeah.
Okay, thank you.
Thanks.
Who's next? Is it Kelly? And Kelly and Wes, are you coming together?
That's okay.
Yeah.
Yeah. Grab a chair. Is there? Can we still? Oh, sorry. Yeah.
Come right over here.
All right. This first. It's not switching. Okay, might just show like that. Okay. One moment, sorry. Laptop. Try this again. Sorry, Ron. Just do it like this. Okay. Good afternoon. I am Kelly Champney. I am the Vice President of Revenue Strategy and Performance for the UVM Health Network. Thank you for having me and seeing everyone again.
And I'm Wes McMillan. I'm the Assistant Vice President and Chief Pharmacy Officer.
So I'm going to jump in. There's a short presentation. Devin did a great job outlining. So really want to just highlight some points and then answer questions and have a conversation. The key takeaways we put in, the front, because that's really where we want to get to the conversation is first, affordability is what we're all trying to work on. And to kind of go off from where Devin left off and where we were discussing, we're working on that actively between the Green Mountain Care Board, work with Mike Smith, the liaison, as you all know about, or some of you might know about. I'm happy to answer questions. We committed in our work with the Green Mountain Care Board to look at outpatient pricing and not look at, but reduce those. We have worked with actually certain payers in reducing the revenue as we're talking about pricing here. And as Devin said, what payers pay us. Some payers have engaged in specifically reducing infusion drugs pricing, but also radiology and other areas that are a high cost concern. We're working with VAHS and other states, designated agencies and others. And again, you've heard from Dr. Ethan, Dr. Leffler, Jessica Michella, I believe, came here to talk about what we're doing in high value care And not just budget models, but how we're working to get the care out of the system, which is what we're talking about here in terms of revenue and covering. So appreciate affordability, working on it, working on the sustainability, and can go into detail in any one of those. The key takeaways with this particular legislation is, yes, there's high prices and high cost. And I think the conversation got to where the model is that's the margin. And you saw it in Rutland, and margin is not just a financial term. It's what we're paying for rehab services, other services that the costs are not paid for by the revenue, whether it be their higher Medicaid populations using those services or simply the volume in those services. To get to the adjustment you mentioned in terms of adjusting community care and primary care, we've had conversations that would actually impact the patients who have high deductible. If you're increasing how much those services are, that could actually limit access. If someone's coming in and we're raising primary care up to $600 a visit because we've got a balance and that's what the cost, that can actually impact the pocket of the patient. So there are these variables working with the partners, working with our partners in the health system and payers. So we did put up, and this is where Devin left off, the legislative and regulatory approaches. There's a lot going on, and I will just say candidly and transparently, it's not lip service. We are all doing this work. We're committed. We are reducing our revenue and our charges. There's differences there, but we're also waiting to see the impact. I won't go into the federal. There's enough conversation there. But state alone, we're working with the Green Mountain Care Board. There's reference-based pricing. We are modeling reductions, not only again in infusion, but radiology and lab. And if you take this one cut in one big blunt area, that actually limits our ability to right size where we've got some higher cost in other services that we've seen and we're looking. So this is a blunt tool, understanding why and understanding the emergency, but we're also looking at where it's not going to intersect and it's going to prevent not only the expansion, it's going to prevent right sizing of some of the services we're committed to doing. It goes beyond the solution, and I think that's where the conversation was, is we understood it, the premiums with Blue Cross really being the concern. You know, this impacts all payers. It impacts out-of-state payers. It impacts, you know, Blue Card of outer-state payers. So if someone from Blue Cross of Florida is here visiting, they get Blue Cross rates. That's the way our contract has to be set. And this cut will go to them. And a lot of our revenue under the Blue Cross contract, over 40%, sometimes up to 47%, comes from the out-of-state Blue Cross payers paying for us. And some of that is Vermonters who work here that are covered by Blue Cross Mass, but those premiums are out of state. So this is a blunt instrument that's going far beyond just kind of the critical stopgap as we're working to a bigger solution change. And then, you know, there is what we've heard, there's still margin, right? How Medicare pays. And this is where some drugs, and Devin noted, and Russ can, you know, add on here, is we do pay above ASP 120 for certain, when to purchase the drugs. You know, we have to purchase these. Also, we're not sure, and I don't really want to get caught up in the federal, but if we're 340B cuts are being made, which is very real from what we're seeing, the margin to cover other services is going to be cut. So again, this going into July, and just to get to the time frame, our budgets are being finalized right now. Like, our boards have to vote. They're being finalized to be submitted to the Green Mountain Care Board for next year. And this will go into effect in this year's current budget. So this will already make an impact come July 1, because our budget goes through the end of September. So we're not, and if there is a recoupment of rates, we're capped in our commercial rates through the Green Mountain Care Board. So we wouldn't be able to recoup. And what we would need to recoup right now is, we looked at our commercial, major commercials. So this is actually not the full impact, because there's some other commercials this would flow to. It's about $69 million, about $53 million to Blue Cross. And of that, again, that out-of-state moves, the Blue Florida, the Blue Mass, that is covering about 21 million. I will say these are estimates based on volume, so please take these numbers as a range. But this is the impact to our bottom line. And if you look at our margin from last year, or how to sustain services, this is greater than that. So this would significantly impact the entire organization of the health network. I know critical access was just brought in. We did provide a little bit of an estimate, knowing we want to look at our impact. And that's, you know, couple $1 million to Porter alone, which the reason why the critical access meetings are not supposed to, they're supposed to be cost plus to just cover charges.
I'm sorry, can I interrupt you?
Yes.
I'm confused by your first. So you have a $69 million total impact just by major payers.
Mhm.
53 of that you estimate is Blue Cross Blue Shield of Vermont. And then 21
Of the 53.
of 21 of the
Sorry.
53.
Sorry if that wasn't clear.
Okay. So 16 million from everywhere else, 53 from Blue Cross Blue Shield.
And the major payers, I didn't go broad down because this was quick. We wanted the initial large impact because it was significant enough.
What were your major payers that you calculated?
Cigna, MVP, Excelis, United Commercial, which is no longer quite major, but we pulled prior claim history, Blue Cross, and I already said MVP. Those are the major ones. So before the action, anything, Wes, in terms of our arrangement with ASPs are concerned that you want?
So for the health system in Vermont in general, there's different status of hospital for the 340B program. So not every hospital has access to all the medications within 340B. So outside of UVMC, and I can't recall if Rutland is a disproportionate share hospital, but the other critical access hospitals and sole community hospitals do not have access to 340B pricing for drugs that are approved by FDA for orphan status indication. So that means if somebody has a rare disease and the drug gets approved by FDA for that rare disease, they get orphan status. So as the example that the chair brought up with infliximab, it's used broadly, but it has several orphan indications. And because of that, none of the hospitals outside of UVM and maybe Rutland can buy that drug at 340B. So they have to buy it at the GPO or group purchasing organization price point. So that can be substantially different or is substantially different. And so the ASP is probably tracks closer to the 340B price point than it does the GPO price point. And there are an awful lot of patients in Vermont that receive that therapy for Crohn's, ulcerative colitis, rheumatoid arthritis, whatever it may be. So it's a substantial hit for those hospitals to move from their negotiated contracting price point to a cap ASP. I looked at CVMC because I have easy access to their medication list, and there were 3 or 4 examples, which kind of the top 10 medications, one being infliximab. So the ASP is roughly $46 per billing unit. $31 per billing unit, and the cost to CVMC is approximately $46. So $15 per billing unit, which is only 10 milligrams in most drugs. Most dosages for that are 400, 500, 600, 700 milligrams. So a substantial change in reimbursement for that one therapy, or in this case, acquisition cost to CVMC. So for them, if you annualize that, it's about a $200,000 hit for just that one medication. Another example is a drug called golimumab or Simponi Aria. That it's very similar. The cost per billing unit, so the acquisition cost is $19. The ASP reimbursement is $11. So even with an additional 120% on top of that, it doesn't cover the cost of the therapy, and that's about a $300,000+ impact just to CVMC. Another highly utilized therapy within the state of Vermont. So if you please.
Could you give us the highest, the drug that you buy for $10 and then you charge whatever, let's say 600% of that $10. What's the highest and how many of those are you using?
So there's over 10,000 line items in our charge description master. Probably the one that we spend the most on is a drug called pembrolizumab. And it's a therapy that's used commonly for cancer. It started off as a small indication of use, and it's being studied in more and more cancers. So our utilization of that product is very high, but it's also very expensive. I can't remember. I don't know off the top of my head what the acquisition cost is, but it will say 10,000 plus for one dose of that therapy. So the way that most charge description master drugs are built is the cheaper the drug is, the more the markup. So the reason why, so like acetaminophen, Tylenol, one tablet is a penny. So my time as a pharmacist, the tech time, all the administrative overhead that go into, repackaging that product is not covered by that 1 cent acquisition cost. So we may have I'll just make it up, a 10-fold markup. So now it's 10 cents as opposed to a penny. So 10-fold sounds terrible, but in reality, 10 cents is not much. As you get up more expensive, the $10,000, $20,000, $100,000 products, we can't do a 10x markup on $100,000. So it incrementally, drops down as the price point goes up. So for those more expensive drugs like pembrolizumab, our markup is very small. The other piece is that the hospitals, the way they do their fee schedule or their charge description master, is we choose an acquisition price point, because you have some people that are 340B eligible. You have some that's GPO. You have some that we also dispense that are wholesale acquisition costs. We have different contracts with manufacturers, or we buy directly from the manufacturers. So the price point that we get in the door is hugely variable. And it's different from between hospitals and across hospitals. So even within our system, we have different acquisition costs. So for our chart description master, we set a standard. This is what we're going to use, and we can stay consistent with that. So it's not variable to our payers or to our patients or, to ourselves from a budgetary standpoint. So we have that set as our acquisition price point, and then we do the markup on top of that. And that's to cover, the administrative overhead. And as Kelly has brought up and Devin before, it's really, that markup is to help offset the losses for Medicaid, specifically on the infusion business, but also some of the gaps in Medicare, with the payment acquisition cost.
Thank you.
I'll add, it's not the model, I think, and this is, it's not excuse, but this is not the model that reflects necessarily like the cost and then, X margin on each, to your point of that 1 penny should only be 3, right? It's not a margin we love. That's why a model we love. It's why we are moving. And that gets to the next points of, we're moving in this area to look at specific drugs that we need to limit. We're looking at the patient out of pocket. And that's what I was talking about before. It's not just the insurance cost. Part of the pharmacy issue is it's not under our control, a lot of it, right? These are the drugs that the prices change. We have to purchase the new technologies. We have drugs we're providing in this state. CAR T, it's a life-saving cancer treatment that we provide in this state. The drug on average is $500,000 to come in our door. We don't have 1,000% markup on that because we can't. And we don't actually get a markup for most payers. There's the government payers are sometimes less, even the drug coming in the door. So this is a balancing act of how do we want to provide those services, or does someone have to go to Boston for CAR T? I mean, that's some of the conversations. So these are the things we're working on through reference-based pricing. And that's our recommendation is there's a lot of good work in process. There's a lot of good work. Having a blunt instrument July 1, has a potential for a real impact to all our hospitals. It's not just about the health network. So we would like to support to continue that work, which is going on. And then, I do add in there's insurance market changes, that can occur through stakeholders looking at our entire insurance market, how we support the payers to succeed. And also just look at what we're doing as a state with other insurers potentially, how do we look at the models that are there, the benefits that are in, and I think there's a broader conversation that everyone is willing to have.
Another question?
All this good work that you're talking about that you're doing now, how does that compare to the 2.5% we're talking about?
In 126.
Oh, sorry. All this work is part of that, so for example, if we're cutting, I don't have numbers yet because we're on reference-based pricing. If we're cutting $20 million out, that's all part of this work. And that's where this reference-based pricing of pulling from radiology rates. I'll just say radiology, lab, infusion, and certain surgeries are generally what hospitals need to look at. That will all go into that work and the commitment. And that's where we're working with Boz, working with Mike Smith, working with the Oliver Wyman report. So it's all a point of it. Could we take $12 million out of infusion as part of that, as one component? We're looking at what models can come out. So this is all part of that in terms of our budget filings and, commitment. We've got these buckets we're working on.
Cory? Everything you just said, though, is that all reference-based pricing? Because my concern there is that's not gonna be for a couple of years.
So we're working to make, and it candidly got put on pause with two payers this year because of everything going on, and not just with us, the payers. So, we were looking for 7-1 to reduce radiology rates. Like we want in this contract negotiation, we've already done it with one payer. We want to reduce those rates, and that will be for a 1-1.
Okay, so that's something you're doing separate from the reference-based pricing
yeah.
ordinance in 126.
Yeah, and I also think in movement of services, so what can we get to one of our hospitals out in the medical center to Porter, because it's less expensive and we have access there. So we're looking at the interfacility, it's called, and maybe not even a Porter, to Rutland. And I think that's the work that's going on with Bob and others. So this, is it gonna be by July? No, but this is a 1-1 we're working on with preparing our budget and how we want to work with our payers.
Is that the date? 1/1, you mean?
When our contracts renew with our payers is 1/1, which aligns with their plan year.
That was a date. Just
Yeah.
I just have a little bit of question around outpatient hospital drugs. So obviously, you don't administer anything at the health network because I think that's just office people. Does the health network purchase all individual drugs that are then, okay, so
That's Wes's area in terms of drug access.
who makes, is it, because the health network's been in here multiple times talking about how, greater efficiencies with volume and everything. So the health network purchases. How is that accounted for in the individual hospitals who are actually dispensing these? How is that accounted for as far as moving it from the network into the hospitals?
So right now, the drugs are still procured locally. So we have, a pharmacy technician who does drug procurement at each hospital. We do, right now, we don't have a central distribution, if you will, of pharmaceuticals. I think that's on our roadmap to get to a lower price point. Right now, it's very difficult because we have a disproportionate share, a critical access hospital, some community hospital. And so those are 3 different price points that we have to manage through. And so there are some technological solutions that we can implement through centralization that we're just not there yet. So right now, all the procurement happens through the local partner. We do work as a system around contracting, so working with the manufacturers, our wholesale distribution, so doing more contracting work that's broadly applicable. We do central.
Not sure. I think I wanted to. I was thinking about how the money moves around. So if everything is essentially purchased by the network, the individual hospitals have to then buy it from the network for their books. And I'm thinking about the movement of the money on hospital budgets, the books of the individual hospitals, where it's positioned. And the other thing is, you were talking about, this would be great. And I realize you are not going to answer this today because there's no way. And if you have this knowledge off the top of your head, you're amazing. I would really like, you were listing these very, very costly pharmaceuticals. A lot of them cancer drugs. I would be really curious to see the price of these drugs at the UVM Medical Center and the price of these drugs at Champlain Valley Physicians Hospital, both network hospitals. So maybe if you could give us like the top 5 drugs. And I'd also like sort of a comparison between the amount that Blue Cross Blue Shield of Vermont pays to the medical center. And I'd like to know roughly what Blue Cross Blue Shield of New York, and I do realize they have lots of New York Blues, but how much they're paying when the service is delivered over at CVPH. That would be, yeah,
We just have to respect the different contracts.
Yeah, I do. I mean, I can go on your price transparency tool and I can see that,
The
but
nuances of the, and transparency tools are great, and we're doing a great job. I think there's, as we all know,
yeah,
nuances in them. So I think, we can work to get wholesome information for you.
that was it. Sorry. Did I interrupt anyone?
Stacy got it.
I don't think she has her hand up. It's just your microphone.
Oh, that's a different thing. I'm sorry.
I think it's Kelly's
It is.
little avatar of the. All right. Well,
Thank you for listening to us, and we'll follow up.
Thank you. Mr. Fisher? Thought you'd like to speak to this.
Hi, thank you. Mike Fisher, healthcare advocate. Well, first off, thank you for bringing us to this point. I think it's really important. And I think maybe I'll just make a couple of high-level comments before we often talk about sort of who's going to have to pay for these prices, and it's often referred to in sort of industry terms, one carrier or another. And I just wanted to level set. It's us. It's out of our pockets. It's out of our neighbors' pockets. It's out of the small business down the street or our municipality, our tax, our taxes to pay for our public employees. It's Vermonters. Sort of thinking about wanting to have a level tone as I sat with you, but I'm working to quiet a level of frustration that I feel at this moment. I was sort of asking myself, how often have I been told, I've been in this role since 2017. How often have I been told, if you just give us some time, if you just let us do this process, if you just let us finish what we've started, it's going to save Vermonters money. It's going to work. It's going to save our system. It's going to, we're going to coordinate care better. We're going to, all great promises, all great theory. And we know the outcome. So, I want to respect and appreciate what the hospitals have just said about how hard they're working and about how much they get it that we're in a crisis. I want to really honor that because I do hear a different tone from them. And then I also want to say we need to make sure that it's going to happen this time. And so I think it's a both end. I think I'm curious to see the outcomes of the Mike Smith group. I'm curious to see whether rural health redesign amounts to any real savings and real transformation. I don't know what to call it other than the May 1st group, May Day group, that is an engagement with hospitals to come up with real savings. I'm curious about what the outcome will be out of the language that Representative Houghton put in 167. All of it is a good effort at bringing people to the table and collaborating. I can't point to anything, pausing on that because I'm questioning myself. Correct me if I'm wrong. I can't point to anything that's been done this year that actually makes sure we're going to see some reduction in the spending. Other than this is the one thing I can point to that, I'm just imagining in a few short months, we'll be sitting in front of, the actuaries, the decision makers who are going to be listening to the actuaries about the rates. And there's no sort of promises like we think we can make this work that's going to result in a reduced rate. it's something that's going to have to be, that world works on advice from actuaries, be it the board's actuary or the carrier's actuary or my actuary. So I guess I'm trying to sort of calmly sit here and say with some urgency, the proposal you have in front of you, I think is really, really important and is a important counterpoint, comparable, riding alongside all of those other efforts. I appreciate the recent edits that have been done to it that I think Ledge Council walked through this afternoon. I think that does a good job of taking care of some of the details. I heard this discussion about whether Brattleboro counts as CAH or doesn't count as a CAH. And I'll just say, from my perspective, with the negative margin they're reporting and how small they are, and I don't know whether I'm running afoul of anyone else, but if it were up to me to define it, I'm not pointing at Brattleboro here. I personally would count them in that group of hospitals to not have this provision applied to. I want to recognize on your webpage, there is quite a great set of comments that have come in from Vermont businesses and people who represent ratepayers, people who pay the bills. When I heard the chair speaking on the floor this morning, and she started to say that she was focused on who didn't testify, I was expecting, maybe just went to a different direction. It has been a bit of a mystery to me in the mix of all this thing. It's not a usual thing for the healthcare advocate to be the business advocate, but man, that's kind of what I've been saying often in this seat this year. So I just really welcome. I think it's really important that the business community voice has as a part of this through the letters that came to the editor. The chamber's letter, I think, is important.
We did have the chamber in here one time. I can't remember what it was.
Oh.
Merge mark.
See?
A long time ago.
So appreciate their voice here in this as well. And I just ask you to hold to this and keep moving forward. And I think it's vitally important and I'll use the term, when do you know if you're in death spiral?
Mm-hmm.
Probably too late. I mean, I think we probably are. When do you know that healthy lives are fleeing the market and it's just sicker people stay in it, creating a spiral of higher and higher costs? The only way to avoid continuing that spiral is having a shock to reduce the rate increases. Thank you. Yes.
On the spot.
That's why I'm here.
In your opinion, this 120, we know who will help, but plenty of testimony. Who do you feel that is going to hurt?
Thank you for that. I don't question one bit the testimony from the hospitals about this is going to hurt. There's just no two ways about it. We have to get some money out of the system, and taking money out of the system is going to hurt. And I also appreciate sort of a little bit of a counterbalance, the bluntness of it versus an ability to be over time more deliberative and careful and nuanced. In a way, this I balance it a bit with the recognition that this is 1 year. And that the board is going to have the ability to moderate it and do some work to make it right.
So is there a way to do a pilot program of 1, 2, or 3?
You don't, it's kind of what we're doing. doing the non-CAH hospitals, it's well, eight,
Oh, six non-CHA.
six, yeah.
Okay.
Six. There's just no two ways about it. Either we're gonna save the money and reduce the rates, or we're not. And we're, not doing this is a message to the small business community and individuals, because the loss of the enhanced tax credits is gonna be disastrous. Sorry for doing too much. And to individuals this year, not doing this is a statement that you can afford higher rates. And I don't think anybody wants to say that, but that's the outcome. If we can't pull this off, we are staying the course of what we have done for a long time. And we can't keep staying that course.
And then Leslie.
So besides the hospital, is there another entity that we should also be looking at? I mean, it's all on the backs of the hospitals right now.
Yeah. Yeah, it's the structure that we have. We don't regulate the rest of the healthcare industry and the prospects of trying to, I could go down that road with you, but boy, that's a tricky one. This is the system we have, where we have hospitals with budgets we regulate, and it is where a high percentage of the healthcare spending happens.
The highest.
It's around 40% of the healthcare dollar. I'm being rough here. I don't know exactly what it is. 40% of the healthcare dollar is spent at Vermont hospitals. So the other portion is spent at non-Vermont hospitals and non-hospital providers. But yes, it is.
It's the most expensive part though.
Yeah. And I also want to appreciate the energy that the chair entered into early in this conversation about just how shocking, shocking the rates are. And I know that hospitals aren't doing that because they're trying to gouge people. I know that, that they're not, I wouldn't ascribe those terms to it, that it has some intentionality of attempting to take advantage. I know that they feel backed into it, but the outcome is the same. From the person's perspective who has to pay the bill, the outcome is the same. They have to pay tens of thousands of dollars more for a medication that they need to stay alive.
Leslie.
So the question came up about only applying the cap to qualified health plans. I was just wondering what you thought about that.
Back in the day, I used to just worry about the individual group and the small group. I used to think the large group was okay. They're all right. They got enough people. They can spread it around. Wow, that's not the case anymore. I used to, again, not worry about people who are large enough to self-fund. I have all kinds of criticisms about our world of self-funding. But wow, I mean, people call me to tell me about the situation they're in and the wall that they're backed up against. And I hear from businesses, larger businesses who self-fund or who are in the large group who are absolutely backed against the wall with rate increases, whether it's from Blue Cross or from Cigna, that are putting them under. This is system-wide.
Any other questions? All right. Thank you. I think we're done for the day. We will have a schedule tomorrow morning, I promise you, even though we don't at the moment.
You got 266? Somebody come
Yeah.
in.
So, no, not tomorrow. So don't think, because it's not there now, check the